Hello, I'm just going to do a test. This is Marchette from Epilepsy Alliance, Florida. I just want to do a quick test to make sure that everybody can hear us. Can someone put a note in the chat to let us know that you can hear us? Okay, great. We heard someone, they all can hear us. So first I want to thank everybody for joining us today for our very first Epilepsy Unplugged for the love of healthcare. This is an interactive forum that provides an opportunity for you to ask questions and learn more about epilepsy. Today we have Dr. Seinfeld, who serves as the medical director of epilepsy at DiMaggio Children's Hospital, and Dr. Zakaria, a board certified neurologist at Memorial Neuroscience Institute. So this is an open forum for you to ask questions. Any questions that you have, we have someone here that can answer your questions for pediatric and for adults. So please put your questions in the comment section, and we are going to get started with some questions that you guys have sent over to us. First question is for Dr. Seinfeld. What are the common signs and symptoms of epilepsy in children, and how do they differ from adults?
So when you look at epilepsy in pediatrics, you want to have the same event that occurs again and again. It should occur in all situations. So one of the biggest things is that a child that's going to school and spending so much of their time in school should be having events in school and home. So something that only happens in one location makes you think that the differential or what you're thinking about may not be epilepsy, but something that's seen at school and at home would raise your concern that you're dealing with an epilepsy. And the event should be the same over and over again. So whether it's loss of awareness, movements, falling, whatever that is, it should look the same each time.
Question for Dr. Zakaria. How does an epilepsy diagnosis and treatment different in adults compared to children?
Mm-hmm.
Hi, everyone. Thank you for having me. It's a great pleasure to be here today and try to share with you some of the knowledge about epilepsy and some of the how we take care of our patients and our family members that have been challenged with epilepsy. So the question is really a good question, and have me kind of think about it for a second. There are a lot of things that's similar between epilepsy in the childhood and epilepsy in adulthood, but there's some differences, and I think Dr. Seinfeld agree with me with that. The main differences, I believe, is first the type of or the reason for the epilepsy. So in kids, you tend to see epilepsy related to either genetic problems or some kind of birth defects or some problems happens during delivery or in the first few years of life. But in the adult side, you tend to see epilepsy related to either head trauma or more related to stroke or degenerative process like patient with dementia or patient with brain tumor. So the main difference will be first is the type or the reason for the epilepsy. And the second thing also that might be different between adult and childhood epilepsy is the type of seizures, so the symptoms of the seizures. So in kids, they tend to have more what we call as absence seizures, where they're just going to space out for a few seconds and then they come back to normal. We don't see that very often in adulthood. We tend to see more focal seizures, so they tend to present with specific symptoms and signs related to that part of the brain that's causing the seizure. In regard to the treatment, however, very much is the same. We tend to use the same kind of medication or even non-medication approach, whether it's surgery or devices. This is very much similar between adult and childhood. So the main differences will be the reason for epilepsy will be different, and also the type of seizure or the symptoms of the seizure might be also different between adult and childhood.
Making me look bad by giving such a good answer.
I've been thinking too much about it.
Thank you, both of you. I have a question for both the doctors. How does epilepsy impact mental health, and what strategies are available for managing the psychological aspects of living with epilepsy?
So we know that epilepsy and anxiety and depression are a bidirectional relationship, meaning that if you have one, you're at high risk to have the other. So we know that it's common for a person with epilepsy to suffer with depression and anxiety. The best thing we can do for those people are choose a medication that may help with those symptoms. So there are certain medicines that can make anxiety, depression worse, and there are some that may improve it. We also know that you need to treat that. So just as a whole, so getting therapy, talking with someone, maybe even taking a medication every day just for that psychiatric diagnosis can be helpful. We want to make sure we address it, because if we can't control the mental illness or the anxiety, depression, mental health issues, then we have difficulty controlling the seizures. So we know that they're related to each other and that you have to treat both for someone to be successful.
Yeah, I mean, I agree 100%. I think that epilepsy and mental health, and especially depression and anxiety, they come as one package. And I think it's very important for the physician and also for the family member to watch and be sure, notice that the patient with epilepsy is not suffering through all this kind of conditions, mental health conditions that a lot of people tend to kind of underestimate or overlook, and they don't really pay attention to it. But it's one of the major challenges that the patient with epilepsy has to deal with on daily basis. I mean, seizures don't happen most of the time; they don't happen every day. But mental health problems with depression and anxiety can have a huge impact on the patient life and the quality of life. So again, I think that we should be very aware of the correlation between epilepsy and mental health problem. We should screen for this kind of conditions, and we should be able to discuss with the patient the symptoms and the treatment option. And it's as important as taking care of the seizures to take care of this mental health issues.
And now there is a question for Dr. Seinfeld. What are the latest advancements in treatment options for pediatric epilepsy, and what factors determine the most suitable treatment approach for a child?
So that's a great question. So the exciting thing about epilepsy, both for pediatrics and adults, is some of the new medicines that have come out. Used to be years ago, there were only a handful of medicines, but now we have so many more options. So I think that just the number of medications, which are going to be your first line, is really exciting. There are new drugs coming out, very specific. So precision medicine is a term that's thrown around where we say this is the cause of your seizures, and this is what we can do to treat it. This would be the best medication. So we look at things like Dravet syndrome and Fintepla or stiripentol. So knowing the cause, as Dr. Zakaria had mentioned, knowing why you have seizures, what's the cause of your seizures, can help us pick the best treatment. So we have these exciting new medications and continued studies. There's a lot of studies for some of the more severe syndromes, meaning kids who are very affected with frequent seizures and developmental delays. They're looking at the different genetic interventions that we can do, which is still very new. So not something that's common practice, but they're doing the studies looking to see, can we change the course if your disease is genetic? Can we do something to improve the course of this disease? In addition, the devices that Dr. Zakaria had mentioned, so you have the vagus nerve stimulator, which has been around the longest, which is an implanted device in the chest, but you also have other implantable neuromodulation, such as the RNS and the DBS, which are now being used in younger patients. So initially when they're first approved, it was really 18 and over, more of an adult practice, but the availability of these for younger patients, again, not for every patient, has been more widespread and being studied. So I think that looking at that, and then the dietary options and what we've learned about the ketogenic diet over the years, and kind of the advancement when you look a decade ago, not eating, sugars and breads was really difficult. Now everywhere you go, there's keto options, keto friendly things. So I think one of the other big advancements is just kind of how society has taken into practice things that we can use to treat epilepsy. With that, I think there was a second part, but I don't remember what the second part was. It was, let's see. So the most, what determines the most suitable practice, it would be what the cause is. So if you have a child who has seizures that they're likely to outgrow, again, you're not going to do an implantable device. You're not, going to use certain medications. Certain medications can be used as a first line, meaning it's the first medication you're on. Other ones would be used in conjunction with other medications. So knowing why you have seizures. Although we oftentimes don't know why, we do know that a lot of these epilepsies are genetic. And if that's the thought, we also kind of take that into account in what we're doing. But fortunately, most people do well. But there is a subgroup of people that continue to have seizures, and we address that with kind of balancing the best quality of life and the best seizure control. Looks like there's a question, can iron deficiency during pregnancy be a factor? So just having iron deficiency during pregnancy is not going to lead to an epilepsy. If that iron deficiency led to a severe catastrophic event like an HIE, meaning hypoxic ischemic encephalopathy. So if you had a difficult labor because you were so anemic, things like that. But just the iron deficiency itself would not be a cause of epilepsy.
We have another question from our Dr. Zakaria. My significant other has recently been diagnosed with epilepsy. What signs or symptoms should I be aware of and prepare for? Are there any specific resources or training programs available for partners or families who are living with someone diagnosed with epilepsy?
Yeah, that's a great question. So I think the first step is for you to help your significant other is try to get to know his type of seizure, what kind of symptoms and signs that he will develop or he will feel or you will see during the seizure. So a lot of patients, they get to have a feeling of the seizure coming, which is called as an aura. So I think it's very important that he will recognize, your significant other will recognize what the aura will be. So whether it is a change in the taste or smell or funny feeling or numbness or tingling, any kind of a preceding symptom that can lead to seizure, the significant other should be able to recognize and tell you that I'm having this feeling. So that's the first step. The second thing is you get to know what he does or she does during the seizure. Whether it will be a brief seizure, he or she will be spaced out for a few seconds and then they come back, or he or she might go into a more convulsive seizure where they start shaking and eyes rolled back in their eyes and things like that. So I think getting to know what to expect is very important, and learning about the type of the seizure, the symptoms, the sign, the feeling, what you would tell from looking outside. That will help you to know that this person is having a seizure. And the next step will be when you recognize that your significant other is having a seizure, what to do with it, right? So I would highly recommend that to get yourself very aware of things that's important, that sometimes can save life of your significant other. Few things, simple things like putting that person on the side, be sure he's breathing, calling 911, not to put anything on your fingers or any spoon or any foreign object in his mouth or the nose. Be sure that he's safe. If he's kind of fall, be sure that this person will not hurt himself or herself when the fall happened. So just common sense kind of thing, in addition to learning how to deal with person with seizures. And there's a lot of resources that you can learn from. I think that the Epilepsy Alliance of Florida will be a great source for you. There's a lot of things online that you can learn from epilepsy and what to do, the ABC of epilepsy, and how you handle someone who is having a seizure. Always call 911 if you have any doubt. That's what I tell my patient. If you are concerned, you don't know what to do, call 911. But still, you have to do a few things while you are waiting for the 911. Be sure that this patient is safe, he's breathing. Be sure that you're not there's nothing that obstructing his breathing or his oxygen. So those are things you will learn from different resources. Like I said, the Epilepsy Alliance of Florida will be a great source. There's a lot of other sources online that you will learn from. And again, you're going to have to speak to the neurologist. I think that's my third advice, is to speak to the neurologist and have that direct communication with the neurologist or the epileptologist, asking the physician, when do I call 911, what to expect. So he will be kind of giving you more specific information based on the specific case or the specific type of epilepsy that your significant other had.
Great, thank you. We have another question for the both of you. Are there any specific dietary or lifestyle recommendations that apply to both children and adults with epilepsy?
So the ketogenic diet is a treatment for epilepsy. So there's the ketogenic diet, which is the classics diet. There's like a modified Atkins. There's the low glycemic index. So there are dietary treatment options of epilepsy, but they can be difficult. There's something that has side effects, just like the medication. So you can see constipation. You can see different deficiencies of different vitamins. But it's always important to stay well hydrated. So I think that, regardless if you're using a diet to treat your epilepsy, then you're treating it like a medicine. There's no cheat days. You're following with the physician who's managing it. You're not doing it on your own. You're getting labs. But for the person who's not using a diet to treat their epilepsy, from my standpoint, I always tell all my families, make sure you're staying well hydrated. We have a chart of how much water, kids are supposed to drink. I guess it also goes through adulthood of how much water, because if the medicine is going through your kidneys, you want to make sure that you're not getting dehydrated. Certain medicine side effects may cause you to be a little bit more overheated, and a balanced diet. So especially in the pediatric world, we use weight-based dosing of medication. So if I'm going to weight-base a medication, then if you're eating unhealthy foods, if you're overweight, then you need more medicine, which means more side effects, and there are consequences to that. So just a healthy lifestyle, activity are really the best things about diet. So a well-balanced meal. So making sure, if you're not using the diet as a treatment, then of course everyone can have a treat day, but you don't have treats every day.
Yeah, I agree. I mean, I think that in adult we find it's very hard for the patient to be extremely compliant with those strict or severe type of diet, whether it's ketogenic diet or other diets. But in general, my advice to the patients is that try to avoid too much carb, because that's the theory behind the ketogenic diet, is that it might be related to too much carbs. So try to eat healthy. I guess if you don't want to be on a strict diet, my advice is to eat healthy. And the most important thing, like Dr. Seinfeld was saying, is that to be sure you drink and to hydrate yourself very well. Drink water. So be sure you are very hydrated. I have a lot of patients who say that heat and high temperature and dehydration can lead to breakthrough seizures. So that's something that's very easy, and I think it's very useful to avoid in order to, if we want to minimize the numbers of the seizures.
And one other point is, especially in pediatrics, if there's something that you're eating that causes you not to feel good or causes you to have a seizure, then you should avoid it, right? So just because I don't have a study that says that, Slurpees are bad for you, if every time your child has a Slurpee, although Slurpees are delicious, if every time you have that, your child has a seizure, or every certain time your child has ice cream, they have a seizure. If there are certain things that are triggering something, then you want to avoid the triggers. So even if that's a food that may not make sense in the world of the literature that we already have.
Great, thank you. We also have another question from the chat. How often should you visit the doctor with ongoing uncontrollable seizures with adolescents?
So some of that is based on the individual child. So, if you're making frequent medication changes, you may be seen more frequently. I have some kids that I see every few weeks. I have some kids that I see every few months. I think it's important, especially if someone's having a lot of seizures, to talk with the family regularly. And sometimes that can be done at a visit versus just a phone call. It depends on the types of seizures. So if someone's having staring seizures, it may not be as impactful of their daily life as someone who's having convulsions. I would say, just as a standard, every 4 months, I think seeing a neurologist, if you're not controlled, is important. You also want to make sure, so I know that we are here and we're at a center that specializes in epilepsy, but if you follow with someone who is not an epilepsy specialist, then if you've had uncontrolled seizures for a year, then you need to see another specialized neurologist. So the guidelines clearly state that you need to see not just who you're seeing, you need to see an expert in that field to make sure we're not missing any other causes or workup that we should be doing, or any other treatment options that we can do.
Yeah, I agree. I think that the sooner, I'll leave it this way, the sooner we get the seizures under control, the better everyone will be. So if you are having a lot of seizures, especially during that very critical time of life, as you are turning or transition into adulthood, I think it's very important to be very aggressive in controlling the seizures. Because when you are having a lot of seizures and you take a lot of medications, and things might be, there is a risk of a lot of complication that can happen. So I think that just the same thing when we say that someone with a heart attack, he needs to go to the ER. Someone who has a lot of seizures, taking a lot of medication, still having seizures, and dealing with a lot of challenges, that require a very extensive evaluation and treatment. And I think that as being seen by a comprehensive epilepsy program is one of the most important things that you can do as first step to get things better. Seeing by an epileptologist, having full extensive testing, and going through over all the options that might help to control the seizures. those are things that the sooner we do them, the better we will be. So it's not like we can take our time while patient is suffering with all the seizures and complications and the side effect of all this medication he's taking.
And some of it depends on who you're following with. So some doctors may be very comfortable, doing things over the phone or just talking or using like a MyChart communication. Other doctors, depending on the seizure type or the presentation, may, insist on that office visit more frequently. So some of it is just very important to talk with the doctor, right? Because you should follow with who you feel comfortable with. So if that doctor says, okay, we need to make these changes, then you need to be comfortable with how often you're being seen.
Our next question is for Dr. Seinfeld. How does epilepsy impact a child's development in daily life, including their education and social interactions?
So epilepsy can affect all aspects of a child's life. So some of it depends on the cause. So children who have some type of severe incident at birth, whether that be a stroke or, a lack of oxygen, their development may be significantly delayed regardless of their seizures. But we know a child who's not controlled, that's still having seizures, that becomes a progressive process. So that's why it's so important to get control of seizures, because if you continue to have seizures, it's going to affect how you do in school. It's going to affect how you do in life. It's important to keep in mind that medications have side effects. So as we make medication changes, that can affect how you focus. I know Epilepsy Alliance Florida has a lot of resources with school advocacy and having these different plans in place. If your child has epilepsy, then they should be getting those resources from the school, whether it be extra time, whether it be that, maybe they get assignments. If you're having, kids who have uncontrolled absence epilepsy, which are the staring seizures, if I'm missing, it's like talking on the telephone and I'm missing every other word, it's difficult for me to keep up with the conversation and the learning. So I think that depending on how frequent the seizures are and what type of seizures they are, plus the child's baseline, that can affect how they do in school. When we look at the social aspect, I think they're interrelated. So a child that's having so many seizures that's not able to stay in school or is missing a lot of school for their seizures, that affects their peer relationships. Not everyone realizes, what epilepsy is. So some kids, there's still a lot of stigma attached to it. So I think that Epilepsy Alliance Florida also has some great resources of different support groups for adolescents, just different things like the walks where you can meet other families. Because I think talking with someone and having peers that understand what you're going through can be very helpful. I tell my families that, right? So I'm not limiting your potential. So the goal is for you to live your best life, whether that's seizure free or the minimal amount of seizures. That's my goal for you, is that you have your best life. And that's really what we want to try and accomplish. It's a balance of their seizures, the medicines, and again, finding your support. So whether that be peers from school, whether it be an after school activity, whether it be a club that you belong to or something that's when you met through Epilepsy Alliance Florida, it's important to have that peer support group to make sure that you have family and friends. And I think it's as important for the families as it is for the children. Because I think it's scary for parents to have their child who has uncontrolled epilepsy or even controlled epilepsy go to someone's house and to go do different activities. So I think it can affect wide reaching, but I know that everyone's goal is always best quality of life.
Awesome. We have another question from the chat. So do you have any advice for reflex seizures for parents?
So if you have a reflex epilepsy, it depends from my standpoint what it triggers it, right? So some things are easy to avoid, some things are not. But if you know the trigger of your seizures, avoiding that the best you can, and there are certain medicines. So if your child has a certain trigger and has not been given that diagnosis, talking about it with your neurologist to make sure they're aware that this pattern occurs, because certain medicines can work better for certain type of reflex epilepsies. But unfortunately, outside of, getting control of those seizures. So sometimes we can, even though you have a reflex epilepsy, with the right medicines, we can still control the seizures. So I've seen, children with certain songs that trigger, kids. I had a child who the hot water over her head when she showered was a trigger. You work to change that environment the best you can.
And I think it's very important to distinguish between, to be sure that this is the right diagnosis, because there is something called the triggers, which is something that can lead to the seizure, and there's something called reflex epilepsy, and I don't think that we can know the differences except through all the testing and being sure that this is the right diagnosis. So I think reflex epilepsy, from my understanding, is very rare.
It is very rare.
It's very
I
rare.
100% agree.
And I don't want anyone to think that this is something very common, that if we stop the trigger, we cannot stop epilepsy. Unfortunately, that's not the case. So just be sure that you speak to your doctor, be sure that this is really the true diagnosis, reflex epilepsy, and make the distinction between reflex epilepsy and the triggers that can lead to seizures, but patients might still have seizures without the triggers, if it makes sense.
And then I see a question asking the percentage of children that will outgrow their epilepsy if it's controlled after 2 years. So some of that is related to the type of epilepsy they have. So we know that most children who are less than 12 when they develop epilepsy are going to, if they're able to be controlled, depending on the other factors, most of those children are going to outgrow their epilepsy. If you're 12 and older, then your chances of outgrowing it are different. Age-dependent epilepsies like the Absence epilepsies, your Rolandic epilepsies, those are age-dependent. So even if it's a little bit more than 2 years, you're still likely to outgrow it. But the good news is, and again, the difference between adult and peds is that, younger children are likely to do very well and outgrow their epilepsy as long as we don't find a genetic cause that tells us they're not going to, as long as their imaging tells us that there's nothing that's going on that's going to prevent them from outgrowing it. And if developmentally, as they get older, they're gaining those milestones. So I can't give an exact percentage, but we know that most will do very well.
Yeah, I mean, I just wanted to comment on the question. So the question might not be 100% correct. It's not that the kids will grow out after 2 years from being seizure-free. It's that the kids will grow out of epilepsy after they reach certain age. And that's when they auto transition into the adulthood. So most of the what we call generalized epilepsy, whether childhood absence epilepsy or other syndromes, those patients, we expect that majority of them, 80% of them, will be able to outgrow the epilepsy after they reach the puberty, after they become an adult. And that's when that's the time when we expect them to outgrow their epilepsy. But whether it's a children or adult, after 2 years of being seizure-free, I think is a very reasonable question to ask. Do I still need to be on medication? Did I outgrow my epilepsy or not? That's a big question, and that's there is no right or wrong, answer. It all depends on like Dr. Seinfeld was saying, that it all depends on the type of epilepsy you have and type of your MRI, the EEG. All this tests will help to make the physician, with the discussion with the family and the patient, make the decision whether we can wean off the medication or not. So there are two different things. The first one is, if you're being seizure-free for 2 years, there is a potential that you might outgrow your epilepsy, and you can come off the medication. And then there's also the issue of certain epilepsy type that we expect that it will stop on its own once the child reach the age of puberty or become an adult.
Yep, and the 2 years, when you look at the literature, where that number comes from is that gives you, if you're 2 years seizure-free, that gives you the best chance of staying seizure-free when you come off medication. And it depends on the age of the child, the presentation, when the last seizure was, how difficult it was to control. So there are a lot of factors. So it is very case dependent.
Perfect, thank you. We have another one from the chat. So how often should an inpatient EEG be for a young child with 2 types of seizures?
So there's no specific of how often an EEG needs to be done. So someone, who's having, seizures that are electrographic that you're not clinically seeing, they may need to have those EEGs done more frequently. I'm making the assumption that an inpatient means like an epilepsy monitoring unit stay. So, if you're not going to be able to clinically tell the seizures, so you're not going to be able to look at your child and know, that may require it. If your child's having multiple different events, then that may require it if you're making changes. It's very specific for the child. There's no hard and fast rule that you need to have this amount of EEG done at this frequency. We also know that, even when you look at the shorter EEGs, so not even the inpatient, so a child with epilepsy may not have an EEG may have it at presentation and not have another one until those 2 years of seizure freedom. And that's okay if they're doing well. based on their seizure type, whereas there are other children where things keep changing and evolving and you're getting EEGs much more frequently. So it's very case dependent, and there's no number that you need to have. It's based on how your child's presenting. Because although it's a low risk procedure, there's still a risk when you're admitted to the hospital that you can get irritation from your EEG leads. You can have falls. I talk with families all the time, right? When you're in the hospital, you're at home in charge of giving the medicine, giving them on time. That control is taken away from you in the hospital. So it may not always be best if we don't have a clinical question to answer, and if it's not going to change management. So if your child has multiple seizure types, but I know that that these are seizures and this is what we're doing, or we're making changes, there may be no benefit to doing an EEG just to reinforce that, yes, the seizures are still occurring. I don't know, from an adult standpoint.
Yeah, I mean, there is the same thing. There is really no specific duration of the EEG. I guess the point of the test is to, I'm sure before you go to the test, there's a question. And the point of the test is to answer that question. So the timing of the EEG will be based on, did I get the answer of the question I'm asking for? For example, like if you suspecting that I'm not sure this is seizures or not, then I think the timing of the test will be based on whenever the patient get that symptoms or that episode in a question, and then you have the data to say this is seizure or not, then that will be the end of the test. If you are, in this case, I think the question was about having two seizures, it's important to record the two types of seizures on the EEG to see they are similar, they are not similar, they're coming from the same place, they are not coming from the same place. So I guess the question will be based on what's the main indication for the test. And based on that, whenever we get the answer for that question, that will be the enough time for the test.
Okay, we have another question for Dr. Zakaria, but Dr. Seinfeld, you can, of course, comment on this as well. Are there any new medications or therapies on the horizon that show promise for improving seizure control in adults with epilepsy?
Yes, the answer is yes, and this will never stop. I mean, there's always new changes, there's always new advances, there's always some breakthrough, a new treatment for epilepsy. We cannot give up the hope that we will find something not only to stop the seizures but to cure epilepsy. We were having this discussion just a few minutes before we went live, and we were talking about the difference between stopping the seizure and really providing something that can cure epilepsy. And unfortunately, we are not at that stage, but hopefully we will one day reach that goal. But there's a lot of new medication that either were approved by the FDA recently, or they are in the process of being approved by the FDA. Some of them are very promising. Some of them might work through different chemicals or different receptors in the brain. So hopefully that we will see a better efficacy or better control of the seizures with this medication. There's also a lot of advances happening in the field of non-medication related treatment for epilepsy, whether it's a devices or surgical technique that can help to stop the seizures. So I know there's a trial now trying to study the deep brain stimulation, the neuropace, for someone who has a lot of different kind of seizures, multifocal seizures. Try to use deep structure in the brain in order to stimulate the structures and see if that will help to do the seizure. Actually, I have two patients who are off-label now, even though they have not been, the device has not been approved by the FDA, but we did the study as an off-label study, and to see if the deep stimulation of the thalamus, which is a deep structure in the brain, can help to control the seizures. And I will give you more update in regard to the result maybe next time we meet. Right now, the surgeries happened just a few months ago, so we don't have a lot of data, but it can be very promising. So the answer is yes. There's a lot of changes. There's a lot of advances happening in the field of epilepsy, and we cannot give up. We can have to keep going until we reach our goals.
And then in the world of pediatrics, so the genetics plays a large role. So the different genes that can cause epilepsy, if you find a gene, most of them are associated with a significant seizure burden and developmental delays. But we know that if we can say this is the cause of your seizures, we may be able to better figure out what medication. And again, they call that precision medicine. So, someone who, medicine A has been out for a while, but they do much better on this medicine than someone who has a different genetic mutation. Plus, there's the repurposing of other medications that are out there. So maybe a blood pressure medication or a medication used for your cholesterol will help your child control their seizures, or antidepressant may help control your seizures where it didn't in other people, but your etiology or the cause of your seizures responds to it. So I think that plays a large role. When you look at medications coming out, the frustrating thing about pediatrics is things come out and they're typically for adults. So when you look at cenobamate, which is one of the most recent medications, 18 and up. I do have children less than 18 on it, but insurance approval and cost becomes a barrier. And using coupon and the different patient assist programs, you have to be using them on label. So as Dr. Zakaria said, there's certain things we can do off label, but when you have a child who's not in the age range of a medication, it can be difficult to get that approval, and it can be very frustrating. But I do think that people are continuing to work on the different medicines and really looking to see what we can do to prevent seizures in certain populations. When you look at medicines, one of the questions I see is the hour window of giving a liquid medication. You want to do your best. Life happens. I had a colleague used to say everyone misses a dose sometimes, and that's 100% true. If you can stay within that hour, either a half hour in either direction, then that's great. I mean, most medications and most patients within that time frame are not going to have a seizure provoked. There are some children who are very sensitive that if you're just 30 minutes late, then they may have a brief event. So some of it depends on the child itself, him or herself. But I think that if you're not missing any doses and you're doing it within an hour each time, then I think you're good.
I agree with you.
Okay, we have another question from the chat. Will you explain an EEG epilepsy spike versus a complete loop? What is the meaning of abnormal EEGs, and can that be temporal lobe epilepsy? Does all epilepsy show up on an EEG?
So I will start with this question and then I will turn it to Dr. Seinfeld. So there's a lot of questions in this question. I'll start with the last one. Does all epilepsy show up on the EEG? The answer is no. Not all epilepsy will show up on the EEG. Remember that the EEG is recording from the skin, and there's a distance between the brain inside and the skin. There is the skin, you have the muscles, you have the bone, you have the surface of the brain. Some of the epilepsy location can be deep inside the brain. So there's so many different reasons why we might not see changes on the EEG during the time of the seizure. And that's just emphasized the importance of being evaluated by an epileptologist, because we have seen a lot of patients who have been misdiagnosed as having they don't have epilepsy, and then in fact they do have epilepsy, and just using the EEG alone to determine whether this person has epilepsy or not is not the right thing to do. But also there are times where patients might have episodes and there's no EEG changes and they don't have epilepsy. So if you see it on the EEG, then you have a diagnosis. If you don't see it, that will keep the door open whether this is really epilepsy that we are not recording on the EEG, or are we dealing with something else that might not be, that's not epilepsy, could be related to so many different things, but it's not epilepsy. So I think it's very important to be seen by someone who has the experience and the knowledge to be able to work through this situations where you're suspecting epilepsy, but there is nothing on the EEG. The second question is abnormal EEG. So you remember the EEG is a representation of the brain activity, or the normal brain cells activity during wakefulness and sleep. And we expect to see certain morphology or certain frequency of waveforms, just the same thing that your heart, when you record the heartbeats, and you will see this waveform activity of the heart. We do the same thing with the brain. We are recording the waveforms of the brain as they function during wakefulness and sleep, and we expect to see certain frequency and certain morphology during the recording. Any change in the frequency or in the morphology of this waveform activities can be suggestive of something abnormal. Doesn't have to be epilepsy. So like if someone, let's say, has infection or has pneumonia or has UTI sometimes, you tend to see changes in the brain function because of this infection or pneumonia or UTI, but not in the form of the change in the frequency of the waveform activity. So not all the changes on the EEG means that this person has epilepsy. Remember, the brain is very sensitive organ and can be affected by so many things going on in the body, whether it's the blood pressure, the blood sugar, the heart rate, the infection, medications. All of this will have impact on the EEG. So when we see changes on the EEG, we need to know what this changes is. Is it related to the frequency? Is it related to the waveform? Is it related to the morphology? The thing that's specific for epilepsy is, of course, when you see something called spike or sharp waves. Spike and sharp wave are very suggestive of epilepsy, which means that there is this intense firing of the nerve cells in the brain, presenting in the form of spike. And I think that will lead me to the next question. What's the difference between a spike and a complete loop? I don't know what the complete loop here means.
My assumption is that it doesn't mean seizure. So someone can have, so I like to explain spikes and sharp waves to my families as, this one area of the brain that's just too excited. So you have these sparks that are trying to become a fire. Not all sparks become fire, and that's what we use medicines for if it's an epilepsy. Some people, don't need that because the sparks don't require treatment. So you can have an EEG that shows your risk for seizure, which would be a spike, versus a complete loop, which I take to mean, and definitely put it in the chat if you disagree, means a seizure. So just because you have that abnormality, you don't necessarily mean you have a seizure. So especially in the world of epilepsy, in the world of pediatrics, we get a lot of abnormal EEGs. There are other developmental issues that are associated with abnormal EEGs. Every abnormal EEG does not mean epilepsy, but that's why it's so important to have a clinical picture. And that goes along with what Dr. Zakaria was saying of, does all epilepsy show up on EEG? Of course not, right? Because it's a certain amount of the brain needs to be involved. That being said, we also know that if a certain movement or a certain presentation should show up on EEG. So that's why you come to someone who understands and specializes in epilepsy, because we know the difference of this event should have an EEG correlate, whether it be scalp EEG or a deep, invasive type EEG monitoring, versus someone who just says, well, your EEG is normal, that's it. Because we need to take both of those into account. And again, that's why we do what we do.
Yeah, it can be very challenging.
Yeah.
I mean, sometimes we don't know. Sometimes,
and that's true, and that's why we have meetings to discuss it.
Right.
And then temporal lobe epilepsy. So the temporal lobe just means one part of the brain. So temporal lobe is commonly thought of as if your seizures are temporal lobe, you can have a surgery, and that's a very successful surgery. But if you have temporal lobe seizures, we would expect that you would have changes in that temporal area. Possibly your imaging would be abnormal. And those are all things that would come together as, a picture of how you're presenting. But if you get an EEG because you just wanted to get an EEG and it's abnormal, it does not mean you have epilepsy. In the world of genetics, we also know that you can have genetic predisposition. So if there's a family member with epilepsy, your EEG may have abnormalities that tell you that you're at risk, but you may never have a seizure. And that's why you have a discussion with your doctor of, do we treat this? Do we not treat this? And it's a discussion that we have as just kind of a group of clinicians at all of our meetings to figure out the right thing to do. And it changes over time.
Great. So we have a question in the chat. Do you recommend repeating an EEG if seizure-free for 2 years?
I mean, like I said, before we do the test, we have to ask ourselves, what's the question we're trying to answer through that test? So if I presume that the question will be, can I come off the medication? I've been seizure-free for 2 years. Can I come off the medication? I think that's a very reasonable question. And I think doing the EEG at that time might help us to give us more background to make that decision. Even with the normal EEG and being seizure-free for 2 years does not mean that 100% guarantee that you're not going to have a seizure off medication. But it's one of the things that it might give us some kind of prognostic information of what are the chances of having a seizure if I stop taking my medication. If I see the EEG being abnormal, and even though you've been seizure-free for 2 years, but your EEG is abnormal, I have a very high concern that you might end up having a seizure since your EEG continue to be abnormal on medication. You can just imagine what it will be if we take you off the medication. But if the EEG is normal, then that will open the door. Can I come off medication? What are the chances of having a seizure or not? So I think it all depends on the question, why we're doing the EEG. If the question to come off the medication, I think it's very reasonable to get an EEG before we went off the medication.
Yeah, and I think that, there's a lot of other components. So if you have someone who is extremely sensitive or very anxious, maybe that they can't tolerate that EEG, if they're autistic and couldn't cooperate, those things take into account. In addition, if the duration of the EEG that you may get done, and sometimes, insurance plays a role. So if this is something that you've been seizure free and your medicine's at a low dose, and it's going to cost a lot of money to get it, is it the best thing for your child at that time? And again, I think all of those things, and it becomes very patient specific. But I think that most neurologists, if a family feels that they want to do testing, are comfortable ordering some sort of testing to answer that question, especially in the case of coming off medication. But when you look at someone who, and I see it all the time, and I tell families, I don't think you're successfully going to come off medication. You're doing well. Do I need to keep repeating the EEG? I don't, because, right, you've been seizure-free 2 years, but I don't plan on taking you off of medicine because I don't think based on your age that you're going to outgrow it. So that also plays a role. If it's not going to change your management, do you have
There's
to go
no question?
Yeah,
No,
exactly.
Okay, we have a quick question from the chat, and then probably time for one more after this. The question from the chat is, how long do you have to be seizure-free in Florida to get a driver's license?
So I tell all of my families, the way the law is written, it's 1 year of seizure freedom to get the license. There are exceptions, but they're very specific. And I think the adult world's probably a little bit different. But the way it's currently written in Florida, our policy here is 1 year of seizure freedom and compliance with medicine. So if you're on a medicine and we could check a level and you're not taking that medicine, then of course we have to sign off on that form. Every state's going to be different. Florida is not a mandatory report state, but some states, the doctor actually reports to the DMV if you have a seizure, and they can pull your license. So again, if it's a specific situation, like your child's in the hospital and we're testing and we're trying to pull these medications and there's a seizure provoked, but I know what happened, then that may be different. That may not reset the clock. But when you look at getting your initial driver's license in the adolescent period, it's 1 year. I don't know in adults if you.
Yeah, I mean, I think it's case by case basis. I think that based on the law, the last time I checked is that after 6 months being seizure free, if the physician recommend that this person will drive, then they might consider him for driving. So again, I don't think there is an agreement between, I think that every state has its own laws. And like you said, instead of Florida, between 6 months to 1 year, based on the recommendation from the physician, I think that would be a reasonable approach to that question.
Yep, and it's important to remember that when you're asking, the doctor to sign off on driving, you're also asking the doctor to sign off that they think it's safe for you to drive. So that, becomes a very significant issue, because you want to make sure it's safe for not only the patient, but other people.
And this is the last question for both doctors. What advice would you give to someone who has just been diagnosed with epilepsy, regardless of their age?
What advice would you give to someone with a diagnosis of epilepsy, regardless of their age? I always like to say that epilepsy is common. 1 in 26 people have it. So I think that when you get a diagnosis like that, it feels very isolating and very scary. But I think the most important thing to remember is that you're not alone. You have, again, 1 in 26 people. So, I tell kids, if you look at your school, you're not the only person there with an epilepsy. So I think for me, knowing that, there's hope and that we know that this is a common diagnosis and that we have a lot of treatment options. We're luckily in a place where we have so many options of medications and surgery and diet that we have so much hope. And I think from a pediatric standpoint, it's all about the hope.
Yes, 100%. And that's a great question to end this meeting.
It was very well timed.
Well, I was going to say that really the goals or the objectives that every person with epilepsy should have will be to be seizure free, to have no side effect or minimum side effect, if any, and then to have a good quality of life. I think that's what you are entitled for. That's what you deserve as a patient with epilepsy. And I think we have a lot of options. We have a lot of, very good chances that we will be able to achieve those 3 goals. Be sure that you be evaluated in a comprehensive epilepsy program. Be sure that you are aware of your type of epilepsy and what options you have, and just be advocate for yourself. I think that's very important, to not accept things just because the doctor said so. Try to challenge the doctors, try to challenge yourself, try to be sure that you are 100% involved in any decision-making process. And like Dr. Seinfeld was saying, that do not give hope. We have a lot of options. Just be sure that you know what you are doing and you're getting the help you need, and be aware. Please, also, one thing I want to mention is reach out to support group, reach out to the Epilepsy Alliance Florida. You're not by yourself. You're not alone. We are all here for you, to help you go through this. So just be advocate for yourself.
Yeah. Or your child.
Or your child.
But teach them to be an advocate for themselves also.
Thank you. We want to thank everybody who joined us today. We want to thank Dr. Seinfeld and Dr. Zakaria for taking time out today to answer all of our questions. And we really, really hope that we can do this again. Thank you, Dr. Seinfeld. Thank you, Dr. Zakaria. We really, really appreciate your time. And anyone who wants to see the replay, it'll be on our channel. It'll be on Joe DiMaggio and Memorial. So thank you guys, and you have a great day. Bye, guys.
Bye.
Bye.